Greetings, everyone. Welcome to the San Diego Brain Injury Foundation's Saturday speaker meeting. We appreciate having you all here. We have a couple of awesome individuals here that are going to be sharing some information with us. I'm going to introduce them now. They're from NeuroLab360. And so we have Jessie, Agrimis, and if I mispronounced your name, I'm sorry. Jessie is a licensed doctor of physical therapy and board certified neurologic clinical specialist who treats individuals with a variety of neurologic conditions, including brain injury, stroke, vestibular, and balance disorders. We also have one of our newer board members, by the way, full disclosure, Kristine Negrete, who is also a doctor of physical therapy and board certified neurologic clinical specialist and assistive technology professional. That's a mouthful, huh? I look forward to hearing from Kristine. Kristine has extensive experience and passion for working with individuals with brain injury and their families, and hence she is one of our newest board members. So welcome here today. We appreciate having you. And those of you that were at, I'm wearing Survive Headstrong shirt. Those of you that were at Survive Headstrong this year, you may have met Jessie and Kristine because they did the warm-ups. Do you remember them? Did you see them there? They did the warm-ups. They did a great job. So thank you for joining us and spending some time here on a Saturday. We appreciate you very much. And the floor is yours.
All right. Thank you. I'm going to share our screen.
I should have mentioned too, we're going to be really talking about physical therapy assessments, right? After brain injury. And there's some certain things that I think folks should understand about that. And, you all with your specialties, in brain injury, really, I think have probably a very specific and unique take on the type of physical therapy assessments that you do.
All right, well, I'm going to go ahead and get the presentation started. Yes, hello, my name is Kristine, and this is Jessie. Like Kurt said, today we are going to be discussing a physical therapy evaluation after brain injury. So really diving into what a comprehensive physical therapy evaluation looks like, what it includes, and then how that information can really help us drive our therapy sessions to help our patients meet their individual goals. So without further ado, I'm going to go ahead and get started. All right, so before we dive into the physical therapy evaluation, I just want to talk a little bit about different types of brain injury, how therapists and physicians can grade the severity of an injury, as well as stages of recovery. And so I'm sure a lot of you know that a brain injury is defined either as traumatic or acquired. And let me just move this just a little bit so I can... Sorry about that. Thank you. Either traumatic or acquired. So a traumatic brain injury is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. So someone can sustain a traumatic brain injury from, say, a motor vehicle accident. And then there is an acquired brain injury. And this is an injury to the brain, which is not hereditary, congenital, degenerative, or induced by birth trauma. So somebody that has an acquired injury is someone who perhaps sustained a stroke. And so now I'm just going to go into the different types of brain injury that kind of fall under those two categories. Just knowing the type of brain injury that somebody has sustained just gives us as therapists a little bit more information on the extent of injury that occurred to the brain, and it also gives us information on prognosis as well. So there's an open head injury where an object actually penetrates the skull and enters the brain. And then there's also a closed head injury, which just is an external force or sudden violent movement, which causes the brain to knock back and forth. So again, a closed injury, nothing is actually penetrating the skull or entering the brain. This is just a list of different types of brain injury that I'm actually just going to go into a little bit more detail on the next slide. So I'll go for it. A diffuse axonal injury is extensive and widespread damage to the brain due to a shearing force from a rapid acceleration and deceleration. So, if this is your skull and this is the brain, just imagine this kind of shearing force that can happen. And so there's going to be kind of extensive damage done to the brain. We also have a contusion type of injury, which results from a direct impact to the head. It can cause bruising to the brain. And so this is going to be much more localized than that diffuse axonal type of injury. Then we have contra-coup injury. This is where there's a contusion to the site of impact, and then also on the opposite side of the brain from the brain rebounding. So this can be really common in, say, athletes. This is common with concussion. So imagine, a football player falling down to the field. They're going to have that initial injury on the front of the brain as they hit the floor, and as the head comes back up and rebounds on the skull, that's where the injury happens on the back. Then we have a penetrating injury, which I kind of mentioned on the previous slide. This is where a sharp object breaks the skin in the skull. You're at a higher risk for infection, obviously because of the bacteria on the object, and then you actually have an open wound as well. And then there's also hematomas. So an epidural hematoma is when there is a mass of blood between the dura and the skull. So the dura is just this connective tissue layer that surrounds and protects the brain. And this type of injury or this type of hematoma is common with skull fractures and can cause a really fast rate of intracranial pressure. It really goes up. And then we also have subdural hematomas, which is bleeding between the dura and the arachnoid meningeal layers. So these are just the inner layers of that connective tissue that I talked about just previously. And this can be common with more blunt force trauma injuries. And then we have intercerebral hematomas, which is bleeding or damage actually within the brain. And the majority of these occur with our frontal and temporal lobes. So the Glasgow Coma Scale is just a way that the physicians and therapists as well can grade the severity of injury. This is actually used in all types of acute trauma patients as well. And so it's grading somebody's alertness or wakefulness based off of their eye response, their verbal response, and their motor response as well. And so you can see that each category, there's a different numerical value. And when added up, it just gives therapists and physicians alike kind of a picture of what the patient is currently presenting like. And so you can see the lower score is obviously more severe type of injury, and then the higher the score is more mild. And I'm just going to really briefly go over the stages of recovery. It's just important for us as therapists to know kind of where an individual is at in the stage of recovery. And it can help, again, really give us information and help guide our treatments as well. So a coma is just when a patient is unrousable, they're unconscious, there's no really periods of wakefulness. And then there's a vegetative state, which is a lack of awareness, but preserved capacity of arousal. So to be in a vegetative state, there's very strict criteria that has to be met. If somebody's in this type of state in the hospital setting, perhaps a therapist can arouse them by doing kind of like a sternal rub. And then there's a minimally conscious state, which is discernible or reproducible evidence of awareness to self and the environment. So an example of this is somebody just being able to follow a very basic command. And then we have
post-traumatic amnesia. So, amnesia, not being able to remember, right? So this can happen when somebody forgets what happens before their injury, and they can also forget things after their injury. And so the severity of the brain injury is based on the duration of this amnesia. And as therapists, we can use it's called the Westmead Post-Traumatic Amnesia Scale to grade this.
All right, so now the physical therapy evaluation. This is, I feel like, pretty specific to an outpatient setting, but I'm sure that a lot of inpatient therapists as well do the exact same thing, but we just geared it towards outpatient because that's the setting that we work in. So the subjective portion of the exam is really where we get to sit down with our patients, our clients, perhaps their family and their caregivers, and really talk and get an idea of, what their rehab journey has looked like thus far, how things are going at home and in the community, and then really look at what are their goals? What are your therapy goals? What can I help them with, or what can we help them with? So things that we might ask during a subjective eval is, when did your injury occur? What was the length of your hospital stay in the acute setting? And, how long were you in inpatient rehab for? What type of assist do you need with transfers, walking, activities of daily living? Do you use an assistive device like a cane, a walker, perhaps an AFO? And then the biggest one I think of all is the goals for therapy, because again, that's going to drive our treatment sessions. All right, so the objective portion of the exam, this is really comprehensive. This is where we're doing all of our tests, our outcome measures. And this is important because we might pick up deficits here. We might pick up some challenges with certain tasks. And so this provides us with information that's going to, again, really drive our individual therapy sessions. This is just how a objective portion of exam can be broken up, and this is how we're going to present it to you guys. So I'm going to talk about the sensory impairment category, and then Jessie's going to take over. All right, so when we're looking at somebody's sensory system, this can include looking at light touch. So light touch, being able to just sense touch to the skin, proprioception as well. So that's the body's ability to actually sense movement. And then we can look at pain and temperature. And so if we see a deficit here, that means that there's involvement or perhaps damage to our somatosensory cortex within our brain. So if I'm looking at somebody's light touch and say it's absent in their feet, that's going to mean that they're probably going to have some issues with balance and perhaps walking. Proprioception, so the way that we test this is we start at your great toe or your big toe, and we actually move the toe through a range of motion. And we're asking our patients, are you able to sense if I move it up or down? If somebody has an impairment there, say at the great toe, the ankle, the knee, and the hip, imagine how much more challenging walking is going to be if you can't actually even sense where your leg is moving or how it's moving. And then pain and temperature, I think, is just a good talking point for providing patients with education. If somebody isn't able to sense pain and they go and stub their toe and cause a laceration there, they might not even know it. And so that can cause, risk for infection and further injury. So I think those last two are just major education points to talk with the patient and their family as well. So I'm not going to go into this picture in detail, but this is it's a picture of that somatosensory cortex and how this pathway travels through the brain and down toward the spinal cord and into our periphery. And it's just important to note that if there's damage to one side of the brain, you're likely going to present with deficits on the opposite side because of where that pathway crosses over within the spinal cord. Vision is something that can become affected as well after injury. This is just a slide showing the different types of visual field deficits that can occur. So as a physical therapist, we're going to go through an ocular motor exam. So we're looking at the eyes to see if there is any type of impairment or any type of visual field deficit. And I think one of the most common ones that I've seen is number 7 on the slide, or even number 4, homonymous hemianopsia. And so this is where somebody loses complete lack of vision in just one side of their eye. And so this can occur with a damage to the optic tract, as well as damage to the occipital lobe within our brain. And so again, we're going to pick this up from doing an ocular motor exam. This is the ocular motor exam in just a little bit more detail. So all of these are tests or assessments that we're doing. And if they're positive, that'll rule in central involvement, which means that the brain is involved. And so again, this is going to provide us with information that can drive our therapy sessions. We can do exercises to perhaps help this, or maybe things that we need to do to compensate for some of these here. And so if I just say, I talk about saccades. So a way that we assess this is I'll have somebody, straight ahead, and then I'm going to have them switch their gaze from one target to the next, and they're going to go really fast back and forth with their eyes. And what I'm looking for is that individual able to accurately switch their gaze to the target? And so what can happen when there's involvement of the brain or damage to the brain, they can actually overshoot the target or undershoot the target. But this is just an ocular motor exam in just a little bit more detail. I won't go over each and every one of them. All right, Jessie.
Okay, so next we're talking about motor impairments and how this is tested in a physical therapy evaluation. So the first thing that we like to test in terms of the motor system is tone. So after a brain injury, there can be abnormal tone, and there can either be what's called hypotonia, which is where there's reduced muscle tone. It's almost like the muscles are too lax. And then there can also be hypertonia, which it can be in the form of spasticity, which means it's velocity dependent. So when you're moving the joint quickly, it might catch or be tight. There can also be rigidity, which is a form of hypertonia, which is where the muscle is just rigid all through the movement. So if I try to extend an elbow, it might just feel rigid and tight the whole way back down. And then there can also be dystonia, which is kind of like unwanted movements that you can't control in your muscles. Usually, initially, there can be more hypotonia directly after a brain injury, and then hypertonia can set in a little bit later too. So first we'll test that tone, and we'll test it in the lower extremities and in the upper extremities to assess the tone, and that will help us kind of figure out how that might be impacting somebody's walking or motor control, things like that. Next, we'll also look at range of motion. So just looking at each joint and seeing how much flexibility is there. Are the joints able to get in the position that they need to get into for proper posture with sitting and standing and walking and all functional activities like that? And if certain muscles are tight, how is that impacting somebody's walking as well? Next, we'll also look at strength. So we'll test different muscle groups, kind of the major muscle groups of the arms and legs, and kind of screen them. And then we might get a little bit more in depth in certain areas that we think might be a little bit weaker. But testing strength helps us kind of assess whether these muscles that need to help us with our walking are working properly. And we're also looking at specific areas of the brain that correspond with testing strength. So our motor impairment can kind of come from different areas of the brain. And so this is shown in the photo here on the right. So especially the premotor cortex, the SMA supplemental motor area, and the primary motor cortex are the main areas involved with our motor movements. And these are involved in both planning our movements, learning new movements, and actually performing the movements. And we'll talk about some of that a little bit too. So next in our kind of motor impairment evaluation, we'll look at coordination. And so we'll look at coordination of the upper extremities and also of the lower extremities. For the upper extremities, we tend to look at a finger to nose test, which is where you're touching your nose and then the therapist's finger as quickly and as accurately as you can. We'll also look at rapid alternating movement, which is where usually we do flipping the hands over and back as quickly as you can. And then also serial opposition, so touching your thumb to each finger. So we're looking at coordination through those upper extremities. And then in the lower extremities, we'll test different things like a heel to shin test. So that's where you're rubbing your heel up and down your shin, and we're looking at how coordinated is that movement, how smooth is it? And then again, rapid alternating movement, which is usually done with toe tapping. Coordination is testing an area of the brain called the cerebellum, which is it's called the little brain. And it's, I think you can see my mouse when we're screen sharing, but it's this little part down here where the arrow is just beneath the brain. And it helps with coordinating movement, controlling posture, balance, and also fine motor movement. So trying to coordinate our muscles together. It's also very much involved in motor learning. So learning new tasks and how to perform them. The cerebellum helps kind of fine tune everything like that. We grade this in physical therapy on a scale kind of whether it looks normal, whether there's minimal impairment, moderate impairment, severe impairment, or maybe somebody's unable to complete it. And this can also be graded as hypermetric or hypometric. So with hypermetric, then maybe they're overshooting consistently when they're trying to coordinate, and hypometric, maybe they're undershooting when they're trying to coordinate these movements. There can also be different perceptual disorders that we might notice in a physical therapy evaluation. And so one of those is called unilateral neglect. And this is a deficit in attention and awareness of one side of the body and or the environment. And so an example of this is on the right-hand side here. So here, somebody with a brain injury was asked to copy this photo of the flower, the first photo here where it says original. And when they copied it, this was the copy right here. So they only drew petals on the right side of that flower because they have unilateral neglect of the left side. They were also asked to draw a clock here. And if you can see, they put all of the numbers of the clock just on the right side of the clock, because again, they have neglect and they don't notice that there's a whole nother side of the clock over here on the left. Apraxia is another perceptual disorder, and this is where there's an inability to perform purposeful movements despite somebody having adequate strength, coordination, and sensation. So for example, if I asked somebody with a brain injury with apraxia to try to do something like lift up their arm, they might have trouble doing that because they have trouble coordinating it. But if I just handed them a brush and said, can you use this brush? They're able to lift their arm and brush because they are able to do more of that automatic movement. All right. So in our next impairment category, we're talking a little bit about communication. And so for communication within speech, there can be a deficit called dysarthria. And this is a speech disorder that's due to weakness, incoordination, or spasticity of muscles that are used for speaking. Within language, there can also be something called aphasia. And this is a language disorder that impairs one's ability to comprehend or produce language. Both verbal and written can be impacted here. There are three main types of aphasia. One is called Broca's aphasia, or sometimes it's also called expressive or non-fluent aphasia. And this is due to damage of the left frontal lobe right here in purple. This area is called Broca's area. There's also something called Wernicke's aphasia, which is also called receptive or fluent aphasia. And this is damage to the left temporal lobe right here in Wernicke's area. So with Broca's aphasia, there's difficulty with word finding. Somebody might have trouble remembering the word that they're trying to say. With Wernicke's aphasia, there's more trouble with receptive speech. So it's more kind of that you're speaking different words, but they're not really making sense. There can also be global aphasia, where there's aphasia due to damage in both of these areas. For cognition, we can look at memory, judgment, attention, someone's distractibility, so how focused can they stay on a certain task. There can be trouble with information processing. And then also, this is kind of the main one as a physical therapist that we might look at is pathfinding. And so this is somebody's ability to kind of follow directions. And so I use this in outpatient a little bit, but especially in inpatient, kind of trying to find different areas of the hospital using a map or something like that can be really challenging. And so we'll use that because somebody needs that in their daily life to get around and know where they're going. Some of the main areas involved with cognition and especially with memory are the prefrontal cortex in blue, right here, the amygdala, which is right down here, and this is also very much involved in emotions. The hippocampus is right here by the amygdala, and the hippocampus is very much involved in memory and also consolidating our short-term memory into our long-term memory. And then back here is the cerebellum that we talked about for coordination. And we also talked about how it's very much involved in motor learning. So because it's involved in learning, it's involved in cognition as well. And so for both these speech and cognition kind of categories of our evaluation, we're looking to see kind of more vaguely, are there deficits in these areas? And if so, then that would definitely warrant a referral to speech language pathology. So speech therapists, they do a lot more than just working on speech. They also do a lot with cognition and cognitive training. So next we would get into a functional assessment. And so we're looking, especially based on what somebody's goals are, we're looking at their functional mobility in terms of bed mobility. So rolling in bed, getting in and out of bed, scooting in bed. We're looking at sitting and standing balance. We're looking at functional transfers. So standing up from a chair, standing up from a low surface, maybe standing up from the ground. Also transferring from maybe the bed to a wheelchair, things like that. For gait, so for looking at somebody's walking, we always do an assessment where we're kind of documenting and analyzing the phases of gait. So within the different phases of walking, when you're stepping your leg forward or when you're standing on one leg, what does somebody's walking look like? And how does that maybe correlate with what we're finding in our evaluation in terms of their strength and range of motion and tone, because all of those areas can impact somebody's walking. We're also looking at activities of daily living. So the ability to get in and out of the bathroom or feed oneself, things like that. We can assess those as well. And that's also an area that occupational therapy focuses on a lot. For all of these assessments, for functional assessments, we're grading the levels of assistance that's required. So does somebody need my assistance for their balance, or are they able to do it on their own? Do they need an assistive device? That sort of thing. And then we're also looking at the quality of their movement. So maybe somebody is able to stand up, but we notice that if they just lean forward a little bit more, it would be a little easier. Or maybe they're mostly pressing through just one leg and not the other. So we're looking at all of those things because that's what helps kind of drive our treatment, so we know where to focus. There are different outcome measures that are used in people with brain injury to look at kind of where they're at in terms of these different impairment categories. There is something called the EDGE guidelines, and it's guidelines that were recommended by the neurology section of the American Physical Therapy Association. So they have these guidelines for different diagnoses. And so we listed some of the recommended measures for people with brain injury here. There are certain ones that are recommended in the acute care setting, so when a brain injury first occurs, and then there are different ones that are recommended later on in someone's inpatient stay, and then also an outpatient. So in acute care, we're looking more at things such as grading somebody's agitation or the coma recovery scale. The MOS attention rating scale looks at somebody's ability to maintain attention. And then the RANCHO levels of cognitive functioning kind of show us where after a brain injury somebody is in their phases of recovery. We'll talk about that a little bit. In inpatient, again, we can use that coma recovery scale. This scale is looking at things like, the main goal is to see if somebody is coming out of a minimally conscious state. Are they emerging from that minimally conscious state, kind of coming out of the coma? So there are tasks looking at whether they're able to localize to a certain stimulus. Are they able to follow commands, things like that. And then again, looking at somebody's attention using that MOS attention rating scale. In outpatient, one of the very highly recommended measures is called the high level mobility assessment, or the HIMAT. So this is kind of, sorry, my dog is trying to break into the room right now, but this assessment is a much higher level assessment of somebody's mobility. And it involves things that can be very challenging, like running and jumping, things like that. So we're going to show you kind of two ends of the spectrum here in terms of assessment, and Nettie is going to help us out. All right, so next we're just going to talk a little bit more about the RANCHO levels of cognitive functioning, because this is kind of one of the gold standards when somebody is first experiencing a brain injury, and to kind of grade where they're at in their recovery. So this is graded from a level 1 to a level 10. Level 1 means that somebody is having no response. So they're in a coma and they're not able to respond to any stimuli. Level 2 means they're able to have a generalized response. So if you provide, for example, Kristine mentioned a sternal rub, they might have a generalized response, but they won't have a more localized response like a level 3, where they might reach for their sternum because they're able to sense where that stimulus occurred. Level 4 is when somebody can become more confused and more agitated. In level 5, they're not agitated, but they're confused and also inappropriate. In level 6, they're still confused, but now they are more appropriate. So you can see they're kind of recovering. And then in level 7, they're more automatic. So they're able to perform more automatic movements, and they're still appropriate. In level 8, their movements have become more purposeful. And so now they don't need hands-on assistance anymore. They might need more standby assistance. So just kind of nearby in case they need something, and to help keep them safe. In level 9, they're purposeful and they're appropriate, and now they just need standby assistance on request. So kind of for certain tasks, they might need more assistance. And then level 10, they're purposeful and appropriate still, and they're modified independent. So they can do everything on their own, but maybe just with a little bit more time to complete the task. And then on the other end of the spectrum, this is the high mat, and this is something that we use in outpatient only, really. The high mat, so I mentioned it looks at some higher level skills. So walking, backwards walking, walking on someone's toes, walking over obstacles, running, skipping, a lot of jumping, and then also going up and down stairs. And so each of those tasks, we time how long it takes somebody to complete them, and then we score that, and we can track their progress over time. So their total score is out of 54, and then we reassess that kind of on a monthly basis in outpatient therapy to see how somebody is progressing. And the high mat's not appropriate for everybody. We can still use some of the lower level assessments in outpatient, but we just kind of wanted to show you the spectrum of assessments that we have as physical therapists. So once we've completed our whole objective assessment, our next job as a therapist is to perform an assessment. So this is where we do a comprehensive summary of both the subjective information that we got from speaking with our client initially, and then also the objective information. And so this should also include why skilled therapies are required for this patient. And this helps us to create a plan of care. So this is where we develop what the frequency and the duration of someone's treatment should be. So this is based off of that subjective and objective information we received, as well as what somebody's goals are for their therapy, and kind of their potential to reach those goals as well. And then we establish goals together. So short-term goals and long-term goals. It's important to have goals that you can reach in the short term so that you can see your progress, and then kind of realistic long-term goals to strive for with therapy. When we're making goals, these goals should be individualized, so individualized to what is important to each person. And then also we use this acronym SMART. So S stands for specific. So the goal should be really specific to what that person wants to do. It should be measurable so that we know when we've reached it. It should be achievable, so we know that we're able to accomplish it. Realistic, so got to make sure that it's a realistic goal that we can reach. And then also timely. So it's important to set a time frame of when we're hoping to reach that goal. So one thing that we just wanted to mention as well, so we do this whole evaluation, we come up with a plan of care. Sometimes there can be barriers with traditional physical therapy. So if somebody reaches their initial goals, we'll set new goals, but sometimes insurance can limit us to provide as therapists. And so insurance can limit the frequency and the duration of treatment. It limits what we're doing in physical therapy to what insurance deems to be medically necessary versus just what that person wants to work on. And then also insurance can lead to someone experiencing gaps in their care if they're waiting for authorization and things like that. As therapists, Kristine and I also noticed that there can be limitations with hospital-based care. We both worked in big hospital systems before, and so sometimes you're limited in the length of sessions. You might not be able to provide as many wellness services when insurance says that it's not medically necessary to continue physical therapy anymore. And then it can also sometimes be a little bit harder or take longer to develop new programs that might be needed. And so this is part of the reason why Kristine and I started our own clinic. So we just wanted to show you a little bit about it real quick. So our clinic is called NeuroLab360, and we are a cash-based clinic. So that means there's no barriers with insurance. But because we wanted it to be accessible for everybody, we're a nonprofit organization. So we fundraise in order to provide scholarships and keep the costs affordable. All the therapists at our clinic, so it's me and Kristine, and then also another therapist, Megan, we're all board certified neurologic clinical specialists. And then I just kind of listed some of our additional training or certifications below here. So we're very specialized in working with people with any neurologic condition, including brain injury. But our main goal is just to be able to work on whatever our client wants and needs to work on, whether or not it's covered by their insurance, and to find a way to make it accessible because we're a nonprofit. For our services, we offer one-on-one physical therapy and wellness. We have group exercise classes, we have a virtual membership, and then we've been able to fundraise in order to provide a free aphasia group that meets each month, and that's led by a speech therapist. We offer free wheelchair evaluations and cleanings at our clinic. We have a free manual wheelchair skills class. So this is for manual wheelchair users to learn things like how to prevent shoulder injuries, how to get on and off the ground, how to go up and down ramps and curbs and stairs, all those fun things. And then we also have a free Parkinson's exercise class. So we just wanted to share a little bit of information about our clinic with you. These are our email addresses below our names here. You can feel free to reach out to us if you have any questions about anything. And then I also just put our website and phone number in case you'd like to reach out.
So one is, what occurs to me as I start thinking about, physical therapy assessments after brain injury, and start thinking about, what if somebody is, 5 or even 10 years post injury, and maybe they didn't, have access to, great outpatient physical therapy, or maybe it was under an HMO and it was time limited, right? And, those insurance limitations. And what if somebody, is still experiencing some significant, issues or deficits, and, wants to connect with a clinic like yours and, have an assessment, years post injury? Is that something that you've seen happen? And is that something that, you've found sometimes you can help people continue to improve even, years after an injury?
Yes, absolutely. There's a lot of research that even in the chronic state of recovery, that improvement can be made. It's probably going to be a little bit harder. Maybe therapy needs to be a little bit more intensive. So in talking about frequency, like getting in, 3 days a week and doing longer therapy sessions. But yes, we definitely see people far after their injury, and there is research for improvement, and we've seen people make improvement
all the time.
Yeah, and I know that, you mentioned the term motor learning, and kind of thinking about like physical therapy approaches to specific challenges. So you sort of outlined a lot of different assessment mechanisms, right? But then those are going to translate to specific therapies, right? That I'm guessing as a physical therapist, like you would customize approaches to treatment. And so can you talk about motor learning versus like neuroplasticity? And is this kind of one and the same, just for everybody's definitional purposes?
Yeah, they kind of go hand in hand, but motor learning is somebody's ability to learn a new motor skill or refine a motor skill that they already knew. And then we can use the principles of neuroplasticity, which are those principles that help with changes in our brain to help drive motor learning or help encourage it more. So for example, if I'm having somebody relearn how to do a sit to stand, that's the motor skill that they're trying to learn. And then to drive that motor learning, to improve it, we'll use those principles of motor learning, such as specificity is one of them. So we'll practice that actual skill. We'll practice it to stand specifically. Repetition is another. We'll do a lot of repetitions. Intensity is another principle to help drive neuroplasticity. So we'll have high intensity in our sessions. So they kind of work together.
What if somebody wanted to access your group exercise classes? How does that work? And like, is there a cost to that? What's that all about?
Yeah, there is a cost to our group exercise classes. If anybody is interested in joining, they can always reach out to us via email or give us a call. But yes, there is a cost. It's an unlimited group membership that we offer. So we offer one in-person group class every single day. And that unlimited cost is actually $150 a month, but that also gives you access to our virtual classes. So we actually provide 2 live virtual classes every week. And then you also get kind of access to our exercise library. And there's at least 100+ classes on there that you could watch at any time.
And we also do I was going to say, we also do included in the membership is an evaluation with us. Yes. So we do a wellness assessment to see how appropriate is it for somebody to be in certain classes and kind of where are they in terms of their mobility. And then we reassess that. But then we do have those free classes as well, but they're offered more on a once a month basis right now. And as we get more funding, we're hoping to provide more of those classes for free. Yeah, there can be, it's called autonomic dysfunction after a brain injury, where the kind of two parts of that nervous system, like the rest and digest and the more kind of active sympathetic part of the nervous system, aren't in balance. And so there are protocols that you can follow for aerobic exercise to work on tolerating it better. And then also there are things for kind of calming your nervous system a little bit more too in therapy. Like suggestions for like meditation and mindfulness and breathing exercises and things like that to help calm the sympathetic nervous system. But there are definitely ways to do aerobic exercise, kind of, we call it sub-threshold exercise, where we're not challenging somebody past the point where they get those symptoms of dizziness. And then just, of course, monitoring somebody's vitals throughout, their blood pressure, heart rate, things like that, to see how they're doing. But there can be all different causes of dizziness. So you would really have to get a full physical therapy evaluation to know what we can do for that. We can't tell you without doing an evaluation.
Right,
but
right.
We've seen it happen.
Sorry,
before.
that's not a fair question.
I've worked with many. I know people just want to know what's going to happen, but we've worked with people before who haven't been able to tolerate exercise, and after physical therapy, they're able to do it. So,
Right.
I mean, there's definitely potential for it to improve and get better, but I just can't say exactly how much exercise you would be able to tolerate.
You don't know until you try, right? You
Exactly.
don't know until you
Yes.
try.
Yeah, so in terms of memory, like Jessie was saying on our slide, we do a very general screen, as physical therapist. I think somebody that could help you the best would be a speech language pathologist, as Jessie mentioned.
Okay.
One thing to mention as well, aerobic exercise can help improve memory. So performing aerobic exercise helps your brain release neurotransmitters that help your brain cells, your nerves, communicate with each other in your brain. And that has been shown to help improve memory. So if you're not already performing aerobic exercise, or you feel like you need help performing it correctly or to the right intensity, then I would definitely see a physical therapist. Kristine.
Yeah, I'm actually a certified adaptive, certified in adaptive yoga. So I just can incorporate it into my therapy sessions for people that are interested in it. We don't specifically have like an adaptive yoga class that we're doing.
Okay.
But I like to incorporate it into therapy sessions for people that, are in need.
Yeah, and for everybody here to just kind of understand getting more range of motion and getting that active range of motion, stretching does help. Stretching is very important, but active mobility within those ranges can be absolutely key and game changing, because a lot of our people that are post traumatic brain injury, acquired brain injury, and stroke have those limitations. And so somebody with that type of specialization that can actually speak to that and actively work within those ranges is key. So looking forward to meeting you guys and seeing great things out of you. I'm excited about your organization.
No, so that acquired is just a definition. And so you can certainly, go through physical therapy and go through rehab. Absolutely. Yeah. That's just the definition of what an acquired brain injury is. That doesn't mean that you can't do rehab or can't make improvements.
Well, we don't know the specifics of your case, but there's definitely still, even without knowing that, I can still say that there's definitely still opportunity for rehabilitation to assist in some way. There can be a purpose for it, for maintenance, for making improvements, for slowing decline, all kinds of things depending on what somebody is dealing with. But neuroplasticity, those changes in the brain, we can still help to drive that as much as possible through therapy.
All right. Well, I want to give a round of applause to Jessie and Kristine. Thank you so much. We are, well, I guess it's kind of a formal like welcome. Wow, congratulations on 6 months with NeuroLab360. And I'm sure the future is bright for you. The community is really needs providers like yourselves. So thank you so much for what you do.
Of course. Thank you for having us.